Welcome to week 13. In this lecture, we're going to cover part 2 of the lecture that we started last week. We're going to look at the history of mental health treatment. You will learn about 3 major topics: the medical approaches of the early to mid 1900s, the relationship between clinical psychology and World War II, and 2 other treatment options that emerged in the middle of the 1900s, behavior therapy and person-centered therapy, which was part of humanistic psychology. Last week, we learned about some of the earliest approaches to the treatment of mental illness. Then we looked at the reformers of the Enlightenment period, and then we looked at psychoanalysis. We looked at Sigmund Freud, Anna Freud, Alfred Adler, and Carl Jung. This week, I want to turn our attention to the medical approaches. In the 1920s and 1930s, there were several medical approaches that were invented. Most of these medical approaches were used by doctors and psychiatrists. In this section, we will talk about fever therapy, insulin therapy, Metrozol shock therapy, electroshock therapy, as well as the infamous lobotomy. At the very end of this section, I explain modern day lobotomies. They're no longer called lobotomies, but we still purposely, intentionally damage brain tissue in order to minimize the expression of symptoms. Most of these approaches focused on severe mental illness, things like schizophrenia. Today, we have adjusted some of these medical approaches to be used with patients who have obsessive compulsive disorder, major depression, severe anxiety, and less severe forms of mental illness. It's important to realize that the early medical approaches were only tested on a small number of individuals. While some patients enjoyed symptom improvement, the medical approaches did not always work. They did not provide enough benefits to outweigh the risks. Lobotomies, for instance, intentionally damage brain tissue and would sometimes change people's personalities, not just minimize their symptoms, but also change other behaviors that were not targeted by the strategy. An Austrian psychiatrist, Julius Wagner-Jauregg, created fever therapy in 1917. He published a report about how he had intentionally injected his patients with malaria. His patients had psoriasis, which is a debilitating condition that results from neurosyphilis, an infection of the brain. Once his patients were injected with malaria, they suffered from an intense fever for several days. Once the fever passed, 50% of his 8 patients seemed to have fewer symptoms related to the psoriasis. He concluded that the fever in and of itself was what caused the reduction in symptoms. Fever therapy was popular in the 1920s and early 1930s until penicillin was discovered as a cure for both neurosyphilis and psoriasis. Here is an example of how fever therapy was used to treat patients with mental illness. Also in the 1930s, a Viennese physician, Manfred Sockel, created insulin shock therapy. He injected his patients with enough insulin to lower their blood sugar and induce a coma for about 20 minutes. Then he would inject them with enough glucose to bring them out of the coma. This was repeated 20 times, at least, over a period of many days, many weeks. Eventually, after doing this about 20 times, his patients reported some symptom relief. Unfortunately for the patients, this relief was only temporary. Despite this not being a long-term solution, it spread quickly to the United States. In the late 1930s, more than half of mental illness institutions used insulin shock therapy. In this short video clip, you will see a patient undergoing insulin shock therapy. If you don't want to watch, you don't have to skip to the next slide. But if you do want to watch, you will notice that his mouth is open most of the time and he's drooling. This was one of the side effects of insulin therapy, lots of drool. They covered their eyes in order to minimize the amount of stimulation while they went through this therapy. At the same time, a Hungarian psychiatrist created yet another option, Metrozol shock therapy. It was created by Ladislas Meduna in Budapest, Hungary. He noticed that his patients who had both schizophrenia and epilepsy did not experience symptoms after a seizure. He thought he could purposely induce seizures in order to minimize symptoms. He injected his patients with Metrozol, which is a powerful seizure-inducing drug. And while many of his patients did in fact enjoy symptom relief temporarily right after the seizure, some of the patients had extremely violent seizures, so violent that they would break bones, ribs, sprain ankles and wrists in the process. Some of the patients reported it as an extremely traumatic experience and also had retrograde amnesia. Despite all of these challenges, the option spread to the United States in the 1930s at the same time that insulin shock therapy was also becoming more popular. By the end of the 1930s, 2/3 of institutions used Metrozol shock therapy. These two types of shock therapy would eventually be replaced by Electro-Convulsive shock therapy, ECT, in the 1950s. And in 1982, the FDA revoked Metrozol's approval. So Metrozol can no longer be used to purposely induce seizures for the treatment of mental illness. In this brief video clip, you will see a patient undergoing Metrozol shock therapy. If you don't want to watch, skip to the next slide. If you do, you will notice that this patient experiences severe seizures. The staff have to hold the patient down. They've actually got him tied to the bed. This is for his own safety. The seizures were a natural response to the Metrozol. The seizures are not by choice. This individual is not acting. If any one of us were injected with Metrozol, we might respond in a very similar way. All of the patients had seizures. Some were more severe than others. In 1938, a neurologist from Italy, Ugo Carletti, invented electroconvulsive shock therapy, sometimes shortened to electroshock therapy. He would apply electricity to his patient's temples, which would induce a convulsive seizure. Although the first treatment for humans was invented in 1938, Carletti had practiced on pigs, kittens, rabbits for several years before publishing his results from his human trials. Like many of the other physicians and psychiatrists at the time, he believed that it was the seizure, not the electricity per se, it was the seizure that was producing symptom improvement. As soon as it was introduced, it spread like wildfire throughout Europe and the United States. It became extremely popular in the 1940s and 1950s. It replaced the other forms of shock therapy. It was unpopular in the 1960s and 70s, but regained acceptance in the 1980s. Today, it is not as popular as it was in the 1900s, although you can still find some doctors and psychiatrists who will perform it. This is an example of a patient undergoing electroconvulsive shock therapy. At about the same time that Carletti was experimenting with electroconvulsive shock therapy, two neurophysiologists were also experimenting with yet another option. In 1935, two Americans, Carlisle Jacobson and John Fulton, published their work with chimpanzees. They had performed the first animal lobotomies. And what they did was they severed the tissue between the frontal lobe and the lower regions of the brain. So right about here, they severed brain tissue. And they did this in two different chimpanzees. You can see Dr. Fulton with one of his chimpanzees in the image here. What they found was after severing this connection between the higher brain and the lower brain, the chimpanzees were less aggressive. And the good news was their mental functions were not impaired. The damage to the brain had not changed the chimpanzees in any other way except to make them less aggressive, according to these two doctors, according to their research and according to their observations. 1 year after Jacobson and Fulton published their work, a neurologist and a neurosurgeon from Portugal published their results from the first human lobotomies. Their names were Antonio Egas Moniz and Almeida Lima. These two individuals together were responsible for the first lobotomies. So sometimes you'll hear lobotomies of this nature called the Moniz-Lima lobotomy. They used a Lacone, you can see an example on the next slide, to make intentional cuts in the brain tissues of 20 of their patients. Technically, historians refer to this first version as a prefrontal leucotomy with a C, named after the instrument that they used. The first step was to drill 2 holes, one on each side of the head, about right here. Insert the Lacone, which looks a lot like a scalpel, and then move the Lacone back and forth to sever some of the brain tissue. Moniz and Lima had figured out exactly how far the Lacone had to be inserted into the hole, and they figured out exactly at what angle to move the Lacone back and forth. They had practiced on at least 20 patients in order to figure out the procedure. 14 of their 20 patients enjoyed symptom relief. At first glance, this looks like good news, right? And many psychiatrists, doctors, and even psychologists thought that the lobotomy could be the next great treatment for mental illness. The problem was, by severing the brain tissue, Moniz and Lima changed their patients, not just in terms of their symptoms, but also their behaviors, their expression of emotions, the way they talked, the way they walked. Some of their patients would stare out the window for hours at a time. Fortunately, they recognized this limitation and urged others to only use this procedure on patients with severe mental illness. Moniz was awarded a Nobel Prize in 1949 for his work on lobotomies. In the 1940s, two American neurologists, Walter Freeman and James Watt, recreated the prefrontal lobotomy and called it lobotomy. They would lift up their patient's eyelids, insert an ice pick in the space, hammer that ice pick in with a hammer. Once the ice pick was inside the skull, they would move the ice pick back and forth to sever brain tissue. Compared to the Moniz-Lima version, this one was faster, it was cheaper, and according to many people, it was safer. The patients did not have to be put under, they could be kept awake for the procedure. There was less risk of infection, and they were able to cut more fibers using this version than they were with the prefrontal lobotomy. Throughout his life, Freeman conducted at least 3,500 transorbital lobotomies. Eventually, his partner, Watt, gets fed up with the procedure and the outcomes of the procedure and leaves Freeman. Like the prefrontal lobotomy, the transorbital lobotomy also resulted in many of the patients not acting like they did before. Their personality changed, their expression of emotion changed. And once again, many of them spent the rest of their life just sitting and staring. The photo on the left is of Dr. Freeman conducting a transorbital lobotomy on one of his patients. In the image on the right, you see an illustration of how the procedure works. By the early 1950s, more than 18,000 people had underwent a lobotomy of some form. The public was growing more and more uncomfortable with the idea of purposely damaging patients' brains, both the general public and the scientific community. In the mid to late 1950s, several antipsychotic medications were produced. One of them, Thorazine, was referred to as the chemical lobotomy. For those of you who are interested, I'm going to show you a brief clip of a lobotomy being performed in the mid-1900s. If you don't want to watch, go ahead and skip to the next slide. One of the number one questions I get about lobotomies is, are they still performed today? The answer is yes and no. Yes, we still intentionally damage some patients' brains in order to help them cope with the symptoms of chronic depression and in order to treat obsessive compulsive disorder. We use methods like you see here: cingulotomy, capsulotomy, stereotactic surgery, and gamma knife surgery. But technically, no, the modern day procedures are not like the original lobotomies. We do not use Lacones and we do not go through the eye. Let me show you some examples of modern day versions of the traditional lobotomy. Cingulotomy and capsulotomy are probably the closest cousins to lobotomy. In both instances, specific parts of the brain are damaged. With deep brain stimulation, an electrode is inserted in the brain and left there permanently. Electricity can then be used to stimulate that part of the brain. Gamma knife surgery uses radiation to destroy different parts of the brain. In the image on the left, you can see the results of an MRI after bilateral cingulotomy. you can see the four areas, the four lesions in the brain. In the image on the right, you can see what it looks like to have the electrodes implanted in the brain, sort of the location of where they are placed. Again, we don't use lobotomies today. We use other forms of medical treatments. These treatments are reserved for the most severe cases and are only used when the patient has found no other option that works for them. Now let's take a look at the emergence of clinical psychology and how World War II played a role. Prior to World War II, clinical psychologists struggled to make a name for themselves, struggled to be the prominent force in the treatment of mental illness. Many of them assisted psychiatrists and helped administer mental tests. There were very few training programs prior to World War II for clinical psychologists, so most of them learned on the job and through experience. In the early 1900s, clinical psychologists began to protest the APA's focus on research, the lack of representation of applied psychologists. In the early days, clinical psychologists were considered applied psychologists because they used psychological principles to address real-world problems. In 1919, the APA created a division specifically for clinical psychologists. Then in the 1920s, the APA created several subcommittees that focused on bringing a more applied perspective to the organization and to the field. Then in 1937, clinical psychologists and other applied psychologists created their own organization, the American Association of Applied Psychologists, the AAAP. They did this because they were still fed up with the lack of representation in the APA. After they did this, the APA responded by including more applied psychologists, more clinical psychologists in its leadership roles, in its programming, and decided to include their research in its publications. On the next few slides, I'm going to show you some of the events that contributed to the emergence of clinical psychology. There are two major reasons why it was developed when it was developed. One, Lightner Witmer, and two, the APA's actions. Lightner Witmer is known as the founder of both school psychology and clinical psychology. He completed his PhD at the University of Leipzig in Wilhelm Wundt's lab. He also worked with Titchener. He also helped Cattell at the University of Pennsylvania. While he was there, he started a small clinic on campus and began bringing in students, children, who had psychological, emotional, and/or behavioral issues. In 1896, he named what he was doing clinical psychology. So, clinical psychology actually began with a very narrow focus: children in school. Eventually, school psychology would develop on its own, and clinical psychology would expand to include adults, children, in a variety of situations. By 1909, Witmer and his staff had created a team approach. Doctors examined the children, social workers collected information about the children's life histories, their family, their school, their friends, their communities. The other staff members administered mental tests and looked at things like memory, learning, attention. Many different professionals were involved in a single case. By 1931, his records indicate that he had more than 10,000 patients. One of the reasons why Witmer was so successful was because his work provided evidence for the early behaviorists' theories. He agreed that the environment played a major role in behavior. He agreed that family members, friends, teachers, community leaders could have an impact on children's behavior. He believed that many issues could be resolved with therapy, with education, training of some sort. And he even came up with a term for it, orthogenics, the idea that we can teach people to restore their weaknesses, to restore any deficiencies that might be diagnosed. Things began to change for clinical psychologists after World War II. A large number of soldiers were returning from combat with symptoms that could not be tied to physical injuries. American psychiatrists could not meet the demand. They needed extra help. And clinical psychologists stepped up to the plate and helped treat these veterans coming home from war. In the late 1940s, 1950s, and 1960s, we see the number of clinical psychologists in the United States increase dramatically. It wasn't until after World War II that clinical psychologists began to test and diagnose mental illness. Up until that point, it had been done primarily by psychiatrists and medical doctors. Today, this field has even more power than it did in the mid-1900s. Today, clinical psychologists serve as experts in court. They can admit and release patients from the hospital. They can receive third-party payments from insurance companies. But it took many decades to put these changes into place. After World War II, the field began to tackle the lack of training for clinical psychologists. In 1947, the APA set up a committee to study the issue. 2 years later, in 1949, a group met at a conference at the University of Colorado in Boulder to discuss the issue further. The result was a blueprint for graduate training programs. It was called the Scientist Practitioner Model. It was also called the Boulder Model for training because they met in Boulder, Colorado. The idea was that clinical psychologists would be trained as both scientists and as practitioners. They would be taught how to conduct research, and they would be taught how to diagnose and treat different forms of mental illness. Once the Boulder model was put in place, the number of clinical psychologists increased dramatically. By the 1960s, however, some of them were not happy with the Boulder model. They felt like the practitioner side of the job was being neglected. Some of them wondered why they needed to learn how to conduct research. That wasn't part of their everyday job. Why were they spending so much time in graduate school learning how to conduct research? In 1973, another group of psychologists got together in Vail, Colorado, to discuss the issue. The result this time was the PsyD program, the Doctor of Psychology. Using this model, clinical psychologists would be primarily trained to diagnose and treat mental illness. The practitioner side of the job is emphasized in a PsyD program. Now, at the time, the PsyD was not as respected as the PhD. Unfortunately, this is still true today. Many PhDs will tell you that you should go get a PhD and not a PsyD. My opinion is it really depends on what you want to do with your degree and what you want out of your education. I would highly recommend that you at least consider some of the PsyD programs and take a look at what they have to offer. Don't completely ignore them just because of the stereotype. In the third and final section of this lecture, I want to cover two other treatment options: behavior therapy and a type of therapy that came from humanistic psychology. In 1952, a British psychologist, Hans Eysenck, compared 5 studies about the effectiveness of psychotherapy with 14 studies about the effectiveness of mixed eclectic therapies. What he found was disturbing to many psychologists. He discovered that the more psychotherapy, the less likely patients were to recover from their symptoms. We would expect the opposite if psychotherapy worked, and that's not what he found. There were plenty of issues with his methodology, so we have to take his conclusions with a grain of salt, but his work was used as evidence that more treatment options were needed. As a result, in the late 1950s, 2 other therapy options had emerged in the field of psychology. Behavior therapy was based on the principles of behaviorism, rewards, punishments after behavior. It is known as the second force and can be tied back to the work of John Watson, B.F. Skinner. The third force in psychology is called Humanistic Psychology. And from this perspective, we get person-centered therapy. It was also created in the 1950s and can be tied to the work of Abraham Maslow and Carl Rogers. Let's take a look at some of their contributions on the next few slides. Unlike psychoanalysis, behavior therapy is action-focused. It encourages clients to make changes in their lives in order to reduce the symptoms that they are experiencing. With psychoanalysis, much of the work occurs in the therapy session itself. With behavior therapy, patients are expected to work on themselves outside of therapy. Behavior therapy is also targeted. Therapists focus on 1 or 2 behaviors at a time. The goal is to teach the client how to reward desirable behaviors and punish or extinguish undesirable behaviors. The therapist and the client work together to make this happen. Behavior therapy includes several different types of modern day therapies, including cognitive behavioral therapy, therapies based on social learning theory, and applied behavior analysis. The idea is to unlearn bad habits and relearn new habits that actually benefit the person. Although behavior therapy was technically created in the 1950s and promoted in the 60s and 70s, it has its roots in earlier studies performed by behaviorists. Let's take a look at some of those examples. In the 1920s, Mary Jones was able to help a young boy overcome his fear of rabbits. What she did was she placed the boy closer and closer to a rabbit during his meals. So the boy would eat his food, something that some of us would consider a reward, a meal. He would eat his meals next to the rabbit. She would move him closer and closer and closer to that animal until the point where he wasn't uncomfortable anymore. In 1938, Orville and Willie Maurer created a crib pad that would make a sound when it became wet. This was exactly the type of thing that the American public wanted, an application of psychological principles that would help them live their lives, that would make life a little bit easier. In the 1950s, at the same time behavior therapy was beginning to emerge, a South African physician by the name of Joseph Wolpe created what he called systematic desensitization. He would systematically desensitize his patients to different stimuli. He asked his patients to relax and imagine a situation that would normally create anxiety for them. For instance, seeing a tarantula or a rattlesnake on the road. Once they were able to overcome that situation, he would ask them to imagine another situation that creates a little bit more anxiety. Say, for instance, standing right next to a tarantula or a rattlesnake. Once they overcame that, he asked them to imagine the most threatening situation possible. For instance, holding a tarantula or a rattlesnake. These sessions that were done with Wolpe used patients' imaginations to recreate the situations. They were not actually exposed to the things that they feared. In the 1950s, another group of psychologists began to take issue with behaviorism and psychoanalysis. This small group of people argued that behavior is way more complex than either approach proposed. They disagreed with the idea that behavior is a direct result of biological instincts, as suggested by the psychoanalysts. They also argued that behavior is not simply a result of conditioned responses, as might be suggested by the behaviorists. Instead, humanistic psychologists took a much more human-like approach to the study of psychology. They believed that people have free will, that we decide how we behave, and that our behavior depends not only on our decisions, but also depends on our life experiences, our emotions, our moods, our thoughts, all kinds of things. They also believed that people are born with a desire for responsibility and purpose in life. They argued that people have a forward-looking approach to their lives. They think about the future, and those goals for the future matter in terms of why people behave the way that they do. And finally, humanistic psychologists believed that we all have a tendency to want to become the best version of ourselves. And this tendency is innate. We are born with it. From a historical perspective, humanistic psychology was created as a form of protest against the two other forces. It all really started with Abraham Maslow's needs hierarchy theory, and then was further reformed, further expanded by Carl Rogers and his client-centered, person-centered therapy. Humanistic psychology was extremely popular in the 1960s and 1970s. A journal appeared in 1961, an association for professionals who practice these principles was formed in 1962, and then 10 years later in 1972, the APA added a division specifically for humanistic psychologists. Modern day approaches to mental illness encompass humanistic principles as well as behaviorist principles. Abraham Harold Maslow is known as the father of humanistic psychology. He earned his PhD from the University of Wisconsin in 1931. But it wasn't until after World War II and after the birth of his first child that he began to take issue with the other two forces, with behaviorism and with psychoanalysis. He spent most of his career trying to establish a new type of psychology, one that focused more on the unique experiences of humans and less on animal behavior and the unconscious. In order to explain behavior, he proposed a hierarchy of 5 needs. You can see them here on the slide. The needs were arranged from strongest at the bottom to weakest at the top. At the bottom of the hierarchy, we have physiological needs. The need to eat, drink, sleep, and reproduce. The second level includes safety needs, the desire to feel safe, secure, and free from danger, free from threats. The third level includes needs for belongingness and love, the desire to have relationships with others, the desire to work with others. The fourth level includes esteem needs, the desire to like oneself and feel good about oneself. The weakest category of needs is the need for self-actualization. According to Maslow, very few people reach this level. Most of us are operating at one of the lower levels, according to Maslow. These needs drive behavior, they activate behavior. The numbers in the image indicate the degree to which an individual might be satisfied. So let's imagine just for a second that 95% of your physiological needs are met, 85% of your safety needs, 70% of your belongingness and love needs, and so on. Your needs do not have to be 100% satisfied at any one level. He said that these needs can be satisfied through learned behaviors. In other words, we learn throughout our lives how to satisfy these different needs. And we're all driven by different needs. No two people are going to be driven by the exact same needs. Lower needs must be at least partially met before the next level can dominate behaviors. At any given time, one level is the prominent force behind behavior. It doesn't mean that the other needs aren't important. It just means they're not as important as that specific level. If you go back to the image on the previous slide, you can see that 70% of the individual's belongingness needs are met and only 50% of their esteem needs are met. If we were going to simplify this example, Maslow would probably say that this person is operating somewhere between the need for love and the need for esteem. The degree of satisfaction then impacts behavior and personality development. High satisfaction results in positive outcomes. Low satisfaction results in negative outcomes, outcomes that look a lot like mental illness. Another contributor to humanistic psychology was Carl Rogers, who was born in Illinois in 1902. He had a difficult childhood. He was very lonely, and he escaped these feelings by reading. He became interested in the scientific method after learning about some of the early agricultural studies being conducted in the Midwest in the early 1900s. He would then go on to Columbia University to study psychology, where he earned his PhD in 1931, the same year that Maslow earned his PhD. Like Maslow's concept of self-actualization, Carl Rogers' concept of a fully functioning person insinuated that all of us are born with a desire to continuously grow, achieve our goals, and become the best version of ourselves. In order to help his patients become who they want to be, he used positive regard, unconditional acceptance, approval, and love. Early on, Rogers did something that no one else had done. He recorded his therapy sessions and let other researchers observe them and measure different variables that they were interested in. These researchers documented the words that clients would use, their observable behaviors, their expressions of emotions. They paid attention to everything in these recordings. His work helped not only him, but also other therapists figure out the best way to approach their clients and talk with them. You can watch one of these therapy sessions with a client named Richie by clicking on the video. Based on his experiences with his own clients, he created a new type of therapy, person-centered therapy. His idea was to allow the client, the individual coming to therapy, to be in control of the change process. The therapist was there to guide the client, but not tell the client what to do, not tell the client what was appropriate. The therapist was simply there to help, to assist. The client leads the discussion. The client expresses their thoughts and feelings. The client practices and makes the appropriate adjustments outside of therapy. Rogers had several ideas about the role of a therapist, about the things that they were supposed to do and the things that they weren't supposed to do in order to make sure that their clients actually changed, actually improved. First and foremost, he asked that therapists be open, honest, transparent, and authentic. The therapy session was no place for therapists to lie or sugarcoat symptoms, challenges, concerns. He also suggested that therapists provide unconditional positive regard in order to show their clients that they respected them, that they saw them as people of value. Remember, go back to the end of the 1700s, people with mental illness were thought to be useless, essentially. Now we're in the 1950s, and we see several individuals promoting the idea that people with mental illness are still people and they deserve to be treated with love and respect. Rogers also encouraged therapists to show empathy and try to understand where the client is coming from, try to understand what they're feeling, try to understand how they're thinking in order to help them change their behaviors. Hopefully now, after learning a little bit about Maslow's ideas and Rogers' ideas, you can see the connection between psychology as we know it today and the two forces in psychology that developed in the 1950s, behaviorism and humanistic psychology. We have finished our study of the history of mental illness treatment. Next week, we will turn our attention to several different subfields of psychology, including social psychology, personality psychology, and cognitive psychology.